Like I said, Western medicine is great at treating disease, but true health is really, it's preventing the disease. So the more I learned, I felt better, and I thought I have to bring it to my own patients, women who are coming to seek help from me. So what I do today is I basically have this Western medicine, but I put this additional layer of functional medicine, lifestyle medicine on top of it, and we take care of the problems, and even without problems, and it's life changing.
Menopause has long been tabooed and shrouded in secrecy, leaving many ashamed and embarrassed about seeking and extending support for this sacred rite of passage. Well, the spirit and mood have changed, and we're surrendering to curiosity, knowledge, and empowerment. In this podcast, I'm sharing my own experiences and point of view, peeking into the lifestyles and rituals of people experiencing menopause, and tapping into experts for their take on the pausal phase. This is for you if you are one of the millions of people in the menopausal phase or want to support them. I'm Dixie Lincoln Nichols, health and well-being educator and founder. This is the Pause Pod. Hey, sweet peas. Welcome back to the Pause Pod. Today, I'm super excited for my guest, Dr. Deepali Kashyap. She's a board-certified OBGYN, functional medicine practitioner, certified menopause specialist, and an educator at UNLV School of Medicine, shaping the next generation of OBGYN residents about menopause care. An internationally recognized leader, speaker, educator, and founder of Galleria Women's Health, Dr. Kashyap specializes in menopause and hormone health by combining gynecology with functional medicine. Dr. Kashyap, thank you so much for coming on to the Pause Pod. And I'm looking forward to this insightful chat that we're about to have. Thank you for saying yes.
Thank you so much, Dixie. I'm so happy to be here, and thank you actually for giving me this opportunity to talk to your audience and create more awareness. So thank you.
Absolutely. And before I dive in, I just want to say happy World Menopause Month
Oh,
because
yeah,
that's what it's all about, awareness, right?
absolutely.
But let me start by saying this. Your work beautifully bridges the Western way of medicine and functional medicine. Is there a story behind that? I'd love to hear what the story is. I'm sure there is one. Tell us.
So, you're right. There's always a story behind what we do. So, my background, I'm a board certified obstetrician and gynecologist. So, I trained our typical traditional way, and Western medicine is great at teaching us how to take care of diseases. But when about 10 years ago, I was going through a lot of my own health issues, and nobody could give me answers. And I tried reaching out to many specialists, and I had really bad migraines. And everybody told me, actually, my neurologist said, "You're not having migraines, you live in this state of migraines, and once in a while, you're coming out of it." So,
Mm.
as you can imagine, it was terrible. And I just felt so lost and I didn't know what to do. So I kind of turned to Ayurveda, and I started changing a lot of my own lifestyle, and that kind of led me to functional medicine. What I realized was functional medicine was almost like a westernized version of Ayurveda, where there was so much stress on basically understanding why this disease process is actually happening. And I started doing that, and gradually, I mean, now I'm almost migraine free. I do get them once in a while, but it has been a long journey. And what I realized was, like I said, Western medicine is great at treating disease, but true health is really, it's preventing the disease. So the more I learned, I felt better, and I thought I have to bring it to my own patients, women who are coming to seek help from me. So what I do today is I basically have this Western medicine, but I put this additional layer of functional medicine, lifestyle medicine on top of it, and we take care of the problems, and even without problems, and it's life changing.
I love that. Now, how did that integrative approach change the way that you see patients and your relationship with your patients as a physician?
Dixie, that's a very interesting question, and I feel like over past 10 years, it has been almost a shift when I see patients now, it's not really, I don't see a patient coming to me or any number like one, two, three. I see a woman sitting in front of me, and people come with a lot of, because they know this is what I do. So, a lot of complex medical issues. They have gone to many doctors and they still don't feel good. So, what I see in front of me is a woman who is really feeling hopeless, who just wants to feel better, who wants to be heard. And that's what I try to see, like what is it that is really bothering her, and what is her story. Because for me, my story was, I was a mother with two teenagers, with young kids, husband traveling, a really really stressful job, no day no night, being an OBGYN. So my lifestyle, I realized, played a huge role. So of course, I ask the medical questions, but I also ask a lot more personal questions. What is it that you do? Because I see a lot of flight attendants. So again, there is no timing, right? Like there's a lot of casino workers doing graveyard shifts. So I try to understand this woman. What is her lifestyle? When is she sleeping, eating, relationships? And I use that along with her medical history to see what we can do, because a prescription goes only that long. Unless you understand somebody, you cannot even tell them, okay, take this or do this, because for some people it might not even be feasible. So that's the change that has happened for me.
Right. Right. So, in other words, you see the whole person. You're not just seeing symptoms, you are
True.
connecting with them as a whole individual with many aspects to who they are.
Absolutely.
Got
I'll
it.
tell you an example. I'll give you an example.
Hmm.
So I had this patient who I saw few years ago, and I feel like I did everything, whatever I could, to make her feel better, but I couldn't. So then one day I said, just come and let's just talk. And we talked, and then she really opened up, and it had been 6 months, and she just started crying. And she said, my son committed suicide 2 years ago. And I was like, yes, this is a grieving mother, right?
Mm.
Until she had told me, but she probably didn't feel, I don't know, whatever was holding, but that changed. Once she opened up, she told that, we started working a little bit on that. I got her a good therapist. It changed, So you have to understand what this woman is here for. What is she going through?
I love that. It just gave me goosebumps. Just one question, a simple question that went further than what are you experiencing in terms of symptoms? It was like, how are you? And you opened up the door for a conversation beyond just asking what's their pain threshold or their pain level. It went to something emotional, like how are you feeling? And you got
Yeah.
that response.
Yeah, I mean, she had really hard time sleeping, and for her, it was like
Mm.
when her son, and that in that moment when he was thinking of taking his whole life, how hopeless he must have felt. And for her as a mother, she felt, I failed. I didn't see my child suffering. That moment I was not there. So that guilt was just too much.
Right, right. And of course her pain influenced her outcome, her health outcome as well.
Yes, she's not
Yeah,
sleeping.
yeah.
So of course, when you're not sleeping, you're tired, and that's the whole what do you say, like snowball effect.
Yeah, this is so important. It's so important for a woman's health, for doctors to take that approach. And I know it's difficult sometimes because of the limited amount of time they have to deal with patients. But this is really what I think is whole care. Yeah.
Yes.
I want to dive in a little bit into your experience with menopause. What was that like for you?
So I am almost there. I'm not menopausal yet. I would say I'm late stages of perimenopause. Um, for me, last few years have been way better than, like I said, 10 years ago. Like, I really did not understand what was happening to my body. All these migraines, there was no libido, sleep, everything was completely off. And I had no idea what was going on. Uh, and understanding was hard because we really have such limited resources. And as a trained OBGYN, even in medical residency, we do not get any training at all. In fact, we are told that, okay, it will pass, it's just hot flashes. So for me to be able to learn, I really had to I started going to a lot of conferences, started reading a lot. And the more and more women I started seeing, I think that pushed me into learning more. So many things that I hear from my patients every day, you don't read these things in books. And when you see 10 women, or I should say 100 women at this time, telling me the same thing, oh, I have frozen shoulder as soon as I turn menopausal, you know that is the thing. So a lot of it is just listening to women, listening to what they're experiencing, and learning from that. What I'm also experienced right now, it's almost like a roadblock, in the sense that we are so limited in the knowledge that we have. Past 20 years, as you know, after WHI study, there was research done but limited. And I'm seeing patients who have a lot of complicated medical issues, but we have no data to even give information to them.
Yeah.
So at this point, what I'm doing is I'm actually trying to collaborate with a lot of other specialities depending on what a woman is coming, like if she has seizures, so just talking to the neurologist, okay, what can we do, can I use this, is it safe, and looking at studies, whatever we have available, then coming up with a plan, telling the women, okay, these are the risks, these are the benefits, this is the limitation. Let's make a very very collaborative approach as to what we can do.
Yeah, that's what's needed. And thank you so much for being so vulnerable with your share in terms of your own menopause experience, because I think that sends a powerful message to women that even an OBGYN didn't know what was going on with her body. And
Yeah.
so it allows them to feel at ease completely, right? With their experiences. It's not just you, it's all women who are now beginning to learn more. Research is now amping up just a little bit. We know we need more, but we're
Yeah.
all learning and on this journey together as we unfold menopause and as we uncover so much that's unknown.
Yeah, I
Yeah.
mean, you're right. And I've always been very vocal about my own health and what I'm experiencing. And Dixie, what I also experience, and you probably hear it from a lot of women too. I mean, now there is awareness, but I started doing this about, completely 7, 8 years ago. A lot of women would come and they would feel that something is wrong with them, that they are the only ones who are experiencing this. Like libido is such a huge topic, uh, or taboo, I should say. People don't talk about it, and they feel like they are the only one. Something is wrong with me. Why do am I the only one who has no desire? And my husband feels something is wrong with me. So when you open up and you tell them, no, you're not the only one. This is physiology. What you're experiencing is our bodies are changing, hormones are changing, so a lot of it is driven by physiology, anatomy, and you're not alone. We are in this, all of us are in this together, and that makes such a huge impact.
Absolutely. Absolutely. And that leads me right into my next question. You got started a little ahead, but there's some more I want you to dive into here. We all know that women's health is deeply personal. So, how do
Yes.
you create space for women to feel secure and at ease with conversations such as vulvar issues, incontinence, sexual dysfunction? What do you do to make women feel at ease so that they can come in and open up to you about what's happening in their lives?
So important, what you just asked. So my office, where I do consultations, it's not like a typical exam room. It's actually, we have to, it's almost like a lot of my patients tell me, you're like my gynetrist, because
I
they
love
feel like
that.
I feel like I'm coming for therapy, and sometimes they'll stop. They're like, "Oh, I should be talking these things with my therapist, not with you. I'm taking your time." So what we have done is the space. First of all, the environment. When we sit across from each other, and these are two comfortable couches, and there is nothing in between me and the women sitting across me, and that's on purpose. I have just this teeny tiny table where I barely can set my laptop on it, because I don't wear lab coat, or I don't wear a stethoscope. I wear regular clothes, right? So because I want them to feel comfortable, I want to take out that if there is any, authority issue or anything, like, I'm talking to a doctor. I mean, they know they are, but still creating that okay, as a woman, I'm listening to you, right? So that space itself, I think, is the first step. Then number two, I listen. When people start telling, I don't start with just asking all the medical questions. I let them speak, let them tell me what they're going through. And then we also, and I share my own stuff. Okay, this is what I have been through, or this is what a lot of women, things that I have not experienced. I would tell them, I haven't had this yet, but many women tell me they have experienced this. Like, let's say, pain when you're sexually active. So somebody will say, "Oh, it feels like razor blades," and I say, "Yes." And other women have also told me it feels like sandpaper, or it feels like glass in there, broken glass in there. Then some people tell me, "Yes, all that. Now squeeze lemon on it." And someone would say, "Yes, all that, and now put some salt on it." So it just makes them feel I'm not the only one. Yes, there's other women who are experiencing a lot more libido. you know I went through such low libido that I thought, like, that's it, something is really wrong with me. So when people tell me, and they tell me, "Oh, you cannot even imagine," and I say, "No, I can imagine, believe me, I have been there where you have been." So then I tell them more things about myself, they open up, and so we create that environment where once they start, they feel comfortable sharing with me, and I feel privileged that they do feel comfortable. And I always tell all my patients that I'm going to try my best. I can never promise 100%, but I 100 promise I will try my best. That's a 100% promise, and let's see where we get. So
That is a compassionate approach. Very compassionate approach to caring for women as a physician, like not wearing a lab coat. That's
yeah,
powerful because you don't distinguish between roles. It's like I'm here as a woman. I'm just like you. Talk to me. They
yeah,
don't feel intimidated in any way. And some women, when they feel intimidated in rooms because they feel like there's a barrier because of higher education, they may not
yeah,
feel as confident asking questions. But I love how you strip all of that away and you
yeah.
meet women where they are, just as women who are experiencing this phenomenon and wanting to know what they can do to support themselves. I love that. Okay, so one of the things I noticed on your website is that you talk about your four-pillar approach. Like there is an approach to how you care for your patients. Can you walk us through what that modality of care looks like?
Yes, so six pillars, would I say?
Six
So
pillars.
six pillars, yes. So sleep, movement, diet, stress, relationships, and external factors. So, all those things play such a huge impact on our life and health in general. So, first, of course, talking initially, what I gather from them, I call it gathering. When they come to me and they start showing me lab results, I always say, "I don't want to see any lab results today. Today, we are just gathering information. I just want to know you, who you are." So that's my approach. So first time, we try to just get that information, and the second time, then I order some blood work and testing. Then they come, then we look at that, and we make a plan. Then I also have, there are a lot more that I want to do, but again, I do get limited a little bit with the time. So I do have a health coach in my office. So the health coach she helps me in a way to be able to gather really details on their diet, sleep, movement, what we are doing, and we kind of incorporate all that in the holistic plan. So
So is it just you alone at the office, or do you have other medical doctors, like other GYNs, in the office with you, along with the health and wellness coach?
I have a nurse practitioner,
Okay,
because the
okay.
more because right now I'm pretty much 99% of I'm doing menopause,
Hmm.
but I still have my patients who still need their well checks, or even all the patients who are coming for menopause care, they also have other needs, infections and all that stuff. So she does all the gynecology part, the general
Hmm.
gynecology, and
Got
then
it.
I do all the menopause, and then we have a health coach, we have ultrasound tech. So together,
Very
we do, yeah,
comprehensive.
it's very comprehensive.
So let's talk a little bit about your services because you offer an array of services to your patients. You see, you do gynecology, like you just said, menopause support that you do, sexual dysfunction, pelvic pain, etc. In your experience, what are some of the most under addressed or even silent issues women face across their lifespan. What are some of the silent things that you see women experience that people are not really talking much about?
So, number one, low libido.
Mm,
Low libido is so prevalent, and women are not very, again, I understand it's a very personal topic. Many
mm,
women are not comfortable talking about it. Like, you will be surprised how many women tell me that if I do not have sex for the rest of my life, I'm completely okay. I'm just doing it for my partner. And this starts in mid 30s or late 30s, like really pretty much everybody you are. So that's a huge, I think, people don't talk about it. Urinary incontinence is another big issue that women, I think they still talk a lot more than low libido, but that's another issue. And third thing, which women don't talk about, and I think they don't even realize, is the musculoskeletal health. Because we are taught all our life, okay, skinny is good, skinny is good, so women don't eat because everybody wants to be skinny. But in that process, they're not eating enough, they're not eating protein, and body is very good in the sense until we hit 50s or 60s.
mm-hmm.
And if you have not done that work,
Yeah.
in your 70s and 80s, you're going to see a huge decline in your musculoskeletal health, which is not talked about, which nobody is aware. OBGYNs are definitely not taught on that, and even by the time they realize, it's too late. And even on our recommendations, we recommend, the guidelines suggest doing DEXA scan when somebody turns 65. And by the time we do 65 DEXA scans, many women have osteoporosis. We don't have good medications for it, and then really there's nothing much can be done. Versus we do DEXAs at age 50. Many women have either normal or osteopenia, and now you can actually intervene. So I think these three things, among lot others, these three things are, I feel, need more attention.
Right. Share with us one thing for each of those areas that women can do to support themselves. One thing.
I think, let's say, if we have to talk, we start with low libido.
Mm-hmm.
I think having conversation with their partner, that would be the number one step, right? Just explaining to the partner that this is what I'm going through. I'm making an effort, but you have to help me, help help me help us, right? Because it's different for women. Libido is very different than men. For women,
Mm-hmm.
unless, I always say, unless it's transactional, you really have to, a lot of things have to fit into place to feel that.
Yes.
So you
Yeah.
both have to, and intimacy starts outside the bedroom. So that number one. And again, in that itself, I can add another thing. I always talk about some anatomy, but also receptive and spontaneous. Don't always just rely on spontaneous desire. Create that desire, right?
Mm.
Then second thing, urinary incontinence. So, what can they do about it? Simple things we all know, okay, doing Kegel exercises, but we don't get taught how to do it. And I feel also here we don't realize the importance of a pelvic floor therapist.
Mm.
So if we, at a younger age, if we start telling our younger girls to, how we have to go to gym to work out the entire body, but when we are young in our 20s or 30s, when we never think about it, if we also go to pelvic floor therapist even few times and learn how can we use those muscles, that can help us in a lot of things, even in pregnancy, childbirth, preventing incontinence. So I think that would be a simple step to do. Musculoskeletal health, again, stressing on the diet, making sure, teaching our doctors how a good nutrition, like what it makes a difference in somebody's life. Weight training, if we start at a younger age, so that we prevent all those. I think those will be simple, good places where people can actually start, I think.
Yeah. Those are wonderful. I especially love that you said warding off incontinence in the 30s by going to a pelvic floor therapist. I mean, who thinks of that in their 30s? But in reality, that's exactly where the prevention needs to begin as early as then, because by the time you're 40, you're like in perimenopause. And like you said, many women, I know many of my friends who started having incontinence in their early 40s, and it was not
Yes.
something that I was even thinking could possibly happen. I'm thinking, maybe when I'm in my late 50s and 60s, and, which we sometimes tend to consider older, that's when
Yeah.
it's going to start. But so
Yeah.
preventing earlier is such a good thing. I think that's a message that definitely needs to go out to younger people before they hit perimenopause.
Yeah, like, we talk about prevention in chronic conditions, okay, diabetes and high blood pressure. And in functional medicine, what we learn is, if we are completely normal here and let's say there is death here, then we go through, by the time we get to the disease state, there's this huge latent phase where there are no symptoms to the
Mm,
symptoms to disease. So if we start working where there is no symptoms at that stage, we can prevent symptoms and prevent disease and disability and of course death. It's going to happen, but still we can stay healthy until the last day. So prevention is the best treatment.
it's the key. Agreed. Okay. You have a blog called Journey to Health, right?
Yes.
Your blog, right? So I read something on there. You mentioned transitioning traditional methods to a more integrative model. What's the biggest challenge that you face, both internally and externally, in making that shift? And what advice would you give to other clinicians considering a similar path? And I ask that because you are a qualified gynecologist, obstetrician, plus menopause care specialist. So you're bringing so much to your patients, and other doctors who may not be where you are can learn something from what you've done and how you've incorporated all of this into your practice. So, what advice would you give?
So, Dixie, I feel, just like in functional medicine, we say root cause.
Mhm.
You know, if we let's not focus on the disease, let's focus on the root. What's causing that? So, even this current clinical state, how doctors treat patients, I really think instead of course, it's good to treat whoever practicing physicians are, although it gets harder. But if we start focusing at our medical schools and our residency programs, I think that's where we have to make a huge impact, because we're always treating our students, resident, to treat the diseases, and we are not teaching them anything about prevention or
Mm.
about food and nutrition and exercise. I think that's where we need to stress. Another thing, what I felt it, and this is my experience, that the healthcare is very, there's a lot of segregation. You have either MDs who go to your medical school residency, like that path where everything is medicine, 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 surgery. Then on the other extreme, we have our naturopaths or acupuncturist or physical therapist, where they are taught a lot of lifestyle medicine, and they believe in that. And a lot of naturopaths, and again, I'm not generalizing, but I'm just saying a lot of them are against any kind of medications,
Mhm.
surgeries. But I feel the approach lies in the middle. We need both. If somebody's having heart attack, I'm not going to say take ashwagandha, right? But
Mm.
if somebody does not have a heart attack yet, then I'm going to say let's do this, all these things, so that you don't get a heart attack. So really, I think if we can, this our medical schools need to incorporate, have nutrition, lifestyle as a proper subject. And in every residency training, whatever the field is, we need to teach these things. These are not important, they are essential. So if we start teaching our physicians that acupuncture, physical therapy, nutritionist, these are really important elements and we need to incorporate. You cannot I really For me, I cannot practice without these. They're called ancillary services. They're not, they are part of our core, especially for women in midlife. They're essential.
I absolutely love that you said introducing lifestyle into medical school education. Why? Because I'm postmenopausal. I'm 3 years postmenopausal. And I've had to make a total lifestyle shift in order for this to happen. Like the life I lived 3 years ago is not the life I'm living now, simply because my hormone levels have changed. And
Yes.
I feel like there is that disconnect with some of the doctors when it comes to what's happening with my body. It's almost like they don't know what to ask, they don't know what to tell me, and they don't even know what's going on. So,
Yes.
yeah, a whole overhaul is needed, and it will make a
Be-
huge difference.
because they don't know themselves. And in
Right.
their defense, they have never been taught. Like, I'm
Right.
really, now I look back and I'm like, in my residency, I was not taught anything that I'm practicing today.
Wow.
Really nothing at all. And
Wow.
menopause was, and even 10 years ago, I wasn't asking my patients questions about these things. And even if somebody wanted to say, I probably was not even ready to listen. Because if
Wow.
somebody said low libido, I would kind of like probably would shrug it off because I didn't know what to do either, right?
Gotcha. Yeah. Yeah. Yeah.
Then women, the other person gets the message, yeah, she's not ready to listen or she doesn't know what to do, and that's the message everybody's getting, and you just come out thinking, yes, I have to learn with it, live with it, this is what is normal.
Yeah.
um,
Yeah.
but I'm glad it's changing.
Right.
So
And that was going to be my next question. What do you see changing from 7 years ago when you started talking? What are some of your observation in terms of how far we've come from seven
yeah,
years ago?
I think and I can only talk about my practice, I see a huge change.
Yeah.
Uh, a lot of my patients are basically just word of mouth. Like I'll see one person, and in the next month, I'll see like her whole sisters, her friends, and everybody. And so, what I love now is many women who are coming to me, they're telling me, oh, my coworker is your patient. And I was just having a hot flash, and she said, no, go to my doctor, right? And I have people like coming from some hairdressers, a lot of patients from there because they're like, or the nails. One person will come and they are educating. So what I'm loving is women educating other women. You don't need to
Mhm.
suffer.
Yeah.
Go see my doctor because you don't have to live with it. Versus what we were saying, oh, it's normal. It will go away. It's okay. We all go through this. It's normal. Other day I saw somebody who came because I practice in Las Vegas, so it's really hot here, and she's like, oh, I was just at a pool and I had a hot flash. I don't even know who this was. She said, no, go see my doctor. You don't need to have a hot flash. So I love this women telling other women this, spreading this message. So I think I see a shift.
Yeah. And you know what that is? And I'm so thrilled to see that happen because that's kind of where I am now, even with this podcast. It's
Yeah.
community building at its best. And
Yes.
that's how we change the narrative around menopause for everybody, for the scientific community, for the medical community, the educational community, and for individuals, is by community, like each one tell one,
Yes.
share the information in the doctor's offices, at the beauty salon, at the swimming pool.
Yes. Swimming pool. Yeah. And
I love that.
even doctor's offices. The other day I saw somebody and she went to her primary care, but the primary care said, no, hormone therapy is not good. And she said, when I came out, the MA kind of just told me, no, go there. So, like,
Let's talk about hormone therapy. So, bioidentical hormone therapy and other types of hormone therapy has been a big topic of conversation. And so
hmm,
many women have questions and they have concerns about hormone replacement, be it conventional or bioidentical. What are the biggest misconceptions that you hear? And how do you guide your patients in deciding what is best for them?
okay, excellent questions. And there are a few concerns which a lot of women have. So, number one, bioidentical itself. A lot of people don't understand what bioidentical is. I think it's kind of started as a marketing term in the past, and many women think that bioidentical just means the creams that you get from compounding pharmacies. So, this is something I educate them that bioidentical just means hormones which are identical to what your body makes, right? So we do have some really good FDA approved bioidentical options that we can get from regular pharmacies, and your insurance will cover. So that's the biggest, I feel. They're like, oh, wow. So because I prescribe 99%, I prescribe bioidentical therapies. And compounding hormones also have a place. It's like custom made, tailor made to fill in the gap. Or if somebody really wants that, they can use that. So that's the biggest challenge. Number two, which we have all been taught, all the OB/GYN residents, is if you don't have a uterus, then you don't need progesterone. And this is another thing I'm telling a lot of women that, okay, this came from the study or the times when we were using synthetic hormones, which are not bioidentical. So
Mhm.
they are just they can do a little bit, but they are not acting exactly the same way how our hormones work, because it's like lock and key theory and all. Like, it's, too much detail. I won't go into that. But the progesterone, natural progesterone that we are using right now, it actually really helps with sleep, which is a big challenge for a lot of women, brain fog, and calming down. Like, a lot of
Mhm.
women also tell me, I have somebody who works at a veterinary hospital, and she said one day, she's like, the animals who are really aggressive, we put this caution button collar in there. And she's like, sometimes I feel like wearing that collar myself.
I can relate.
Like, and many women tell me that. So progesterone, really, it's not talked about that much. It really helps in relaxation, in better sleep. So I
Mhm.
tell all my patients that, if you don't have a uterus, but if you're having sleep issues, then you can have it. It's not the same as progestin, different
Mm.
profile. It's
Right.
considered much safer. That's number two. Number three, of course, the most common is, it gonna give me cancer?
Yeah.
And that, again, we always talk about. I
Yeah.
give them information a little bit about the WHI trial, how estrogen actually arm had less breast cancer.
Mhm.
And the numbers, the study said, it looked like they said everybody's going to get breast cancer. When we look at numbers, it was 8 extra cases per 10,000 women. Of
Mm.
course, we don't want even a single one,
Right.
but still, 8 per 10,000, and we don't know what their history was. So there's a huge disconnect. So we
Yeah.
tell them estrogen does not cause breast cancer.
Right.
I
Right.
think these are one, some of there are a few more, but these are one of the bigger concerns that I hear.
Thank you for clearing all of that up. And I think it's so important, again, why education is so important. And these conversations need to be had, and the menopause conversation amplified. Because, like you said, people are going based on what the WHI study put out those many years ago and still feel like, okay, if I take it, I'm going to get cancer. Doctors are still telling patients that it's not a good thing to take because they may get breast cancer. And so there's so much misinformation around that women tend to not know what to believe. So, what do you say to women when they go in to have these conversations? How can, if a doctor tells you, your primary care says, well, you shouldn't take hormone therapy because it's no good. What should she say if she wants to know more and she's looking to be educated? What should she say to her primary care physician?
It's not going to be politically correct.
I think the women need to hear this. Like, they need permission from someone who's been doing this, who knows this. They because I feel, again, there's that barrier there, between being educated and being the expert and not knowing, right? So it's like, what do I say?
They really need to tell that, physician, that they need to educate themselves.
I
If
like
they are
that.
right, like, educate yourself. I'm
Yeah.
not telling any doctor that, if you don't feel comfortable, then still give hormones. No, don't. But you owe it to your patients to educate yourself. If you did your residency 30 years ago, science is evolving. That's the beauty of it. Like, 100 years ago, what did we do? They would cut the arteries and let the blood come out. That was the way of treating, right? We would hit somebody with a rock to give them anesthesia, to have them pass out, to do surgeries. Are we doing that? No, we're not doing
Right.
that, right? So we have to evolve. So if you don't know, admit it. I think that's the first step. It's hard, but you have to admit, I don't know enough. And I tell people I see in, primary cares or anybody else, if you are not comfortable, just don't say no. Tell them, I don't know, but go to the doctor who can guide you. I think that's better than just saying it will give you cancer,
Yeah.
right? If
Yeah.
you can do that, you're doing somebody a favor. And then other thing is, educate yourself. Nowadays there are so many resources, there are videos available. We have Menopause Society, our ACOG, uh, lots of resources. There is no reason, if you're treating women in 40s and 50s and 60s, we have to educate ourselves.
Yeah, that's the perfect response. Educate yourself, yeah, and nothing else. And then maybe get a second opinion or go to someone else if that person's telling you something that you're not quite feeling aligned with, right?
Yes.
Yeah.
Yes.
Okay. Let's move on to innovations. On your Instagram, you shared some data around a study that was brought out in Australia. I can't remember exactly what it is, but I know
Yes.
you're obviously into studies and how the medical community is evolving around menopause, etc. Looking ahead, what innovations that are emerging are you excited about?
I'm actually, that study was really amazing. I was very excited about just the prospect of that you can look at the breast density and the blood vessels there and tell the cardiovascular risk. That's amazing because what we also do is, even though I'm just, I shouldn't say just, but I'm a gynecologist.
Yes.
But in assessing every woman, we do look at their breast cancer risk, we look at their cardiovascular risk, we
Right.
do a lot of detailed testing. Uh, but I'm curious to see what comes. Okay, let me take a step back. I see a lot of gaps in our knowledge when it comes to hormone therapy, and especially in women who have complex medical issues. Like, for example, let's say breast cancer. We tend to lump entire breast cancer into one, just breast cancer. And I
Mm.
feel it's a huge category, like women who had breast cancer 2 years ago versus somebody had breast cancer 30 years ago. Whether somebody had bilateral mastectomy or just lumpectomy or one breast out, whether they had ovaries out or not, whether they have BRCA or not, I mean, whether they're obese or not. Like what I'm trying to say, there's a lot of other issues, whether they got chemotherapy, radiation, a lot of different things. So I feel we need a lot more data where we can actually separate these things out and then individualize what somebody's risk is, whether they can take hormone therapy or not. And I say that because I'm seeing a lot of young women who are in their early 40s who had breast cancer, and they had every, like, ovaries out, breasts out, no breast tissue left, and they're suffering. They have osteoporosis, but we're not giving them anything because we say, even though they don't have any breast tissue, there's a chance that maybe teeny tiny breast tissue is left and you can get cancer. Yes, there could be a chance. I don't know what that chance is, but the chance that this woman can have osteoporosis and die because of that is definitely way, way higher. Or she can
Mm.
have a heart attack, that chance is extremely high. So those situations, I think we need a lot more data. We are also doing some studies in my office, like observational office, because we have really high volume of menopausal women. So I'm also studying some of the gaps, looking at what I'm seeing. And it's too early for me to see anything, but I'm hoping in next year or so, we'll also have things to say that can impact menopausal health. I think these are some of, so hopefully we have more data on these, or even women with stroke. Somebody had stroke 30 years ago. Now she is like almost 60 and suffering. I hope we get a lot more data on this, if we can do hormone therapy or not, or what else can we do.
Got it. Now, I have a question. This is just something that I've wanted to know, and you just triggered it by saying stroke. Is there a correlation between being menopausal and having strokes?
If you're not on hormone therapy,
Mhm.
then the risk of our cardiovascular or metabolic profile really changes a lot.
Right.
The blood vessels are stiffer. We are at increased risk for heart attacks, for developing clots. There's a lot of data on this. And if we are indirectly, I'm not 100% sure if there's a data increased risk of stroke, but I would think if you're now higher chances of being obese, high cholesterol, increased inflammation, more insulin resistance. Again, those are the markers for stroke. So I would think theoretically, yes, it would increase the risk. And if I quote data on cardiovascular, most women, like one third of menopausal women, die because of cardiovascular complications. And most heart attacks in women happen when they are menopausal. So there's a huge shift with lack of estrogen affecting our cardiovascular health.
Clearly, you can see that. Yeah. Okay, great. What about, well, I'll come back to that. I want to ask you about your self-care rituals because you do such a great job caring for other women. I want to know how you care for yourself. But I just have one more question for the listeners. Many women who may not yet be in menopause might be facing complex gynecological problems. What are three practical, evidence based habits or mindset shifts you wish that more women would embrace earlier in their lives to better support their long term health, especially as they move into perimenopause and, of course, after postmenopause?
So many. I have a long list. So
You can write a book, right? You get to write, you write the book.
I'm writing a book. It should be
Ah,
out.
look at that.
Yes. So,
Love it.
um, self-care is so important, and I think this will actually even what you asked me what I do. I basically I try to do what I'm telling other women to do, or a lot of times what I'm doing, that's what I share with them. A lot of the things that I do is basically coming from my own health issues. So number one is gratitude, and like I said, a lot of my issues started 10 years ago. So I used to be this type A person before I'm out of the bed in my head. As soon as the eyes opened up, I'm like, now I have this, then this delivery, then this, and then office and my kids. And it's like at days I felt I don't even have to get out of my bed because I've lived the whole day in my mind, right? So one of the changes I did was let me get out of my way. I just gonna in the morning just be thankful. I woke up today. It's gonna be a beautiful day. That's it. And I looks like husband is gonna wake up too, and it's a bonus. Whatever comes my way, I think I can handle it. So that was the biggest thing, starting my day with a lot of gratitude for what I have and being thankful, and then not think about and just get through the day how it's going to be. So that was really big for me because I would wake up with headaches. Then second thing was focusing on, I think we don't think about food, nutrition. I keep going back to that, but I think a really good heavy breakfast is very, very important. So I think if a lot of time people are just waking up 10 minutes before they had to get to work, they're just running, eating on the go. And I think that's really not good because when we are doing that, we're not really letting our parasympathetic system to come into play to digest the food, to enjoy that. So I think taking a little bit of time, and it doesn't take too much, taking 10 minutes, you don't have to say a prayer, but just 1 second of being thankful I have food and enjoying that food, take 10 minutes. I think that's really, really good. Lots of hydration. We know that, but we forget. Uh, Other things which I have incorporated, apart from simple things which a lot of people already are aware, saunas. I do sauna at least 2 or 3 times a week, and I love it. I was experiencing knee pain a few years ago, but now it's completely gone. And I think it's probably because of sauna, because I think sauna is great. So, steam sauna, if you can incorporate, a lot of gyms have it. I tell all my patients to do that. Then exercise, I make it a point to do weight training because it's very important. We are losing muscle, we are
Yeah,
losing bone,
yeah.
so if we can do the weight lifting, so I do that 3 times a week, at least four if I can. And then of course cardio. Then yoga I think is very important. And yoga, I don't mean really, it doesn't have to be hot yoga, it doesn't have to be anything big. Just 10 minutes, if we can stretch our body, our back in all different directions, stretch our neck, just sit down, do breathing exercises. I think that's more than enough. And it's free. A lot of the things are free. And cold showers. Sorry, I forgot that. I'm a big,
Mm.
cold showers free. Boost your mitochondria so much you can do every day.
So are you an advocate for the cold tubs? What do they call
Cold,
them again?
yes, I know what you're
You
saying.
know what
You
I'm
know,
talking about?
I have not,
Cold
I have not,
plunges, cold
cold
plunges. Are you, yeah, are you an advocate for those?
I personally, like I said, I tell people what I do. I have never tried those
Got
because I
it.
don't have one, but I feel like cold shower is easier.
Yeah.
Just at home we can do it. So, but I'm sure
Yeah.
I've heard cold plunges are great, but I've never done those.
Got it. Got it. Thank you so much. This has been incredible. The information has been so resourceful and so insightful. I thank you. And I also want to add happy Cancer Awareness Month because it's also Cancer Awareness Month. And you touched on everything. You touched on menopause, you touched a little bit on cancer. I truly appreciate you coming on to share with us.
Thank you so much. Thank you. I really feel honored. Thank you.
You are welcome. But before you go, I want you to tell us how we can find you and how we can stay connected with you.
So I have a practice here in Las Vegas, but otherwise I have an Instagram account where I basically that's for education. So a
Mhm.
lot of the questions which my patients ask me, and I try to answer that over there. So that's one way to connect. And we have, as you know, we have a website, and we really put a lot of try to put information which people can benefit from.
Got you. Can you drop the name of the website?
It's GalleriaWomensHealth.com.
GalleriaWomensHealth.com. And what's your handle on Instagram?
At Dr. at Dr. Dipali Kashyap.
At Dr. Deepali Kashyap. I'm also going to drop these inside of the show notes so listeners will be able to go get them and follow you. I could talk to you for another hour, but I respect your time.
No,
So
thank you.
thank
Thank you.
you again for coming. Listeners, thank you for tuning in. Let's continue to perimenopause and prosper.